and so that it can start. Okay, so now over to Ellen. Please take us through these findings quickly, and then we can hear also the feeling of the members that are attending this workshop today. So over to you, Ellen.
Thank you, Dr. Kwan. Once again, to everyone, thank you for taking the time to attend this online validation workshop. I am going to take you through this presentation of our research finding on medical waste management. And so since the beginning of this year, Pamela Steele Associates, together with 15 other partners, embarked on a journey to understand medical waste management practices in humanitarian operations under the WAM project. As you can see, WAM stands for Waste in Humanitarian Operations, Reduction and Minimization. And this project is funded by the European Union and has a duration of 2 years. And focusing on the humanitarian livelihood programs and field hospital deployments, WAM is keen to reduce the environmental impact of humanitarian operations by designing guidelines and support actions for circular economy. WAM brings together medical and humanitarian organizations, procurement and logistics service providers, waste management service providers, academic partners through a collaborative and multi-actor approach. This project focuses on 5 key areas. Number 1 is bio-based technological innovation solutions within the humanitarian context. 2, procurement as a gatekeeper for waste avoidance and innovation integration. Innovation and improvement in waste management and treatment. Sustainable livelihood of waste pickers. And lastly, policy development and advocacy. And so we conducted our research, and as part of Pamela Steele Associates' contribution to the WAM's primary objective, we conducted a study on medical waste management in humanitarian settings with emphasis on field hospitals, and also evaluated existing disposal methods in regular hospitals to understand current waste management practices. And we noted that over 5.2 million people, including 4 million children, die annually due to diseases caused by medical waste worldwide. The World Health Organization estimates that 85% of healthcare waste is non-hazardous, while 15% is hazardous, which can be infectious, toxic, or radioactive. And poor waste segregation leads to up to 15% of waste becoming infectious, which poses major health risks. High-income countries generate up to 11 kg of hazardous waste per hospital per bed per day, whereas low-income countries generate up to 6 kg. And without proper disposal, healthcare waste can infect patients, workers, and the general public. Injections are a major source of contamination, with over 16 billion which are administered annually, but the disposal practices are often inadequate, which leading to increased risks of diseases like hepatitis B, hepatitis C, and HIV from needle stick injuries. This situation is worsened in field hospitals deployed during crisis, where waste management is often lacking, increasing the risk of chemical, biological, and environmental hazards. And also from our research, we noted that there are different types of waste that are generated in a healthcare system, and this includes general waste, highly infectious waste, hazardous waste, pathological waste, chemical waste, sharp waste, radioactive waste, cytotoxic waste, pharmaceutical waste, and liquid waste. And so considering WAM brings together different partners, we had a key informative interview with different health facilities in public hospitals, and also had a site visit with them. And we noted that medical waste is categorized as infectious or non-infectious. And in most of the cases, waste gets mixed up at on-site storage before being transported for incineration and disposal. And along this process, under waste segregation, we noted that while healthcare workers recognize the importance of waste segregation, adherence is still low due to inadequate resources. At an on-site storage, most of the public health facilities, they lack basic infrastructure for temporarily storing waste, which results to open dumping and uncontrolled storage within the compound. And at the process of collection and transportation, that waste is transported using basic methods like wheelbarrows or trolleys in some of the cases, and waste workers often handle waste without proper personal protective equipment. And under treatment and disposal, most of the facilities rely on incineration as a method of disposal, but some are slowly transitioning to microwaves, which are new technologies, microwave with shaders and also autoclaves. However, open burning and sanitary pits are still common in some of these facilities. And so just to to understand the perspective of the humanitarian settings, we have a case of MSF. And from the interview with MSF, we noted that MSF handles a variety of waste in crisis, including infectious, pharmaceutical, and non-medical waste, with a significant amount being infectious. Health workers strictly follow waste management guidelines for segregation, collection, transport, and disposal. Waste is handled by trained wash hygiene teams who work in shifts. MSF constructs a complete waste management area using the demote font incinerators, glass crushers, sharp-box pits, organic pits for placentas, food pits, chlorine pits, and ash pits. The grease traps separate wastewater, which is stored in septic tanks or in filtration system. Full tanks are emptied by a validated exhaust machine upon when they are full, and waste from remote dispensaries is usually transported in sealed containers via designated vehicles or donkey carts. And when local hospitals lack incinerators, MSF partners with the local waste management companies for disposal. And MSF sets up drum burners or temporary incinerators in crisis areas. And they have introduced the smart ash burner, which is a high temperature plug and play framework for emergencies, which burn all types of waste, including the sharps. And there are challenges that MSF experiences, which includes rising waste volumes and lack of coordination among partners on the ground. And so from the site visit in public hospitals, we noted that waste management guidelines were visibly mounted on the walls, but adherence to these guidelines remains low in practice. And also we observed that bins were often uncovered and lacked designated liners, contributing to poor segregation and management of waste. In some of the cases where resources were available, best practices were adopted, such as properly covered bins and the use of appropriate liners, showcasing that adherence can improve with better resource allocation. And we also observed that there are no formal or secure on-site storage facilities for medical waste, and waste is often stored in open or uncontrolled areas within the hospital compound, which leads to increased risk and exposure. And both infectious and infectious waste are mixed during on-site storage, posing significant risk to waste handlers and compromising their safety. And in most of the healthcare facilities, we observed treatment and final disposal practices primarily involves incineration and open dumping, and available incinerators have capacities ranging from 50 kg per hour to 100 kg per hour. There were no designated ash pits that was observed. Instead, ash residues are left in the open, awaiting collection and transportation to the dump site. And the ash and other residues are dumped without proper containment, which increases environmental and health risks. And so from the while most of the facilities continue to use incineration for waste treatment, some are beginning to adopt the new technology such as microwaves with shaders. But even with this microwave with shaders, the final shredded waste must be disposed of at a designated site, which adds to the overall cost of waste management. There was a notable lack of secure on-site storage facilities, and both infectious and non-infectious waste are still mixed up, leading to potential health and safety hazards. This is a visual representation of the observed practice in public hospitals, and the visual show that the same liners are used for different types of waste streams, which can lead to cross-contamination. There's an illustration of waste being dumped openly within the hospital premises, lacking proper containment. The pictures reveal that operators handling waste are not using full personal protective equipment, which increases their risk of exposure. And also we observe that bins are not covered, which can lead to spillage and contamination. Also, there is improper storage of sharps, which can pose significant risk to the health workers and also the patients. And then some of the facilities are still using open burning chambers for waste disposal, which is an outdated and environmentally harmful practice. And so we visited the Kenya Medical Research Institute so that we can be able to understand how is medical waste being handled in other settings such as the research institution. And from our observation, we know that they generate different types of waste, which is infectious, general, and liquid waste. And each type of the waste undergoes a specific process for treatment. If it is infectious, it goes through chemical disinfection, then it is autoclaved, then goes to the incinerator. The incinerator has a scrubber element. A scrubber element is a system which purifies the smoke that comes out of the incineration process. And finally, the residue goes to the ash pit. If the waste is general, it goes directly to the incineration process, then to the ash pit. And if it is liquid waste, they have an effluent system. So the liquid waste goes through chemical dilution, then it is further diluted in a sink using water, then it goes to sewer treatment, and the final liquid is used in irrigation in farm by use of the sprinklers. And this is a pictorial observation of the medical waste management practice at Kemri here in Kisumu. The picture show that the waste, there's proper segregation of waste. Then they use the autoclave for infectious waste, which is a new technology, which is environmentally friendly. We also observe that the operator have full personal protective equipment. The final residue from their incineration process goes to the ash pit. And then also there's chemical disinfection, and they have an on-site storage facility for storing different types of waste. Their incinerator has a high chimney, which emits colorless incineration process. Another picture shows a dilution of a liquid waste, then incineration with the filtration scrubber. Then also they have an autoclave equipment for sterilizing of reusable equipment, and their liquid waste goes to the sewer treatment, which the final product is used for irrigation by use of the sprinklers. And this is a summary of the key gaps that we identified. Number one, there is a lack of functional waste management systems. There are no coordinated monitoring and tracking system for waste management at all stages in the waste management chain, from segregation, collection, transport, on-site and off-site storage, and also final disposal. There are limited infrastructural resources and institutional capacity to manage waste effectively. The second challenge that we noted is the use of harmful and destructive disposal methods, such as the open burning, which releases toxic gases to the environment, and poorly designed incinerators, and also waste being mixed at the on-site storage. They have both hazardous and non-hazardous. The third gap that we noted is there's training deficiency and inadequate capacity development. There is limited routine training of staff handling waste, and also there is no formal training curricula designated for waste management. And then there is no waste management guideline specific to field hospital, despite operations in the unique settings. The third gap that we noted is occupational safety of waste handlers. The waste pickers are usually hired on a casual basis with no formal training. They lack personal protective equipment, which exposes them to bacteria and dust. And also government does not prioritize waste handlers. It usually prioritizes other staff compared to them. The final gap that we noted is insufficient dedicated or allocated budgets for medical waste management. Most of the health facilities do not have waste management budget lines, which leads to inadequate supplies of resources such as PPEs and segregation bins and liners. And also there is a limited waste management infrastructure such as the on-site transport and storage facilities. And therefore, we have these are the recommendations that we we recommend that they should regularly train and develop the capacity of medical staff and waste handlers. They should implement advanced technological measures for incineration, including filtration and treatment of emissions to reduce environmental impact. They should enforce stricter adherence to waste segregation regulations, ensuring proper separation of waste streams. They should enhance the availability of both on-site and off-site treatment facilities, including recycling centers. They should implement regular collection schedules and provide adequate personal protective equipment. They should designate a secure area for on-site storage and improve transport methods for waste management. They should establish mechanisms for regular audits and assessments to measure compliance and identify areas for improvement. They should create and enforce clear, standardized guidelines for bio-based waste management tailored to healthcare facilities and waste management providers. For the humanitarian actors, they should regulate material and disposable equipment use to reduce waste generation and prioritize the procurement of biodegradable materials for personal protective equipment and shift away from single-use items. They should establish a filter system for supplies and focus on need-based donations to prevent the accumulation of excess and unusable items. They should emphasize products designed for recyclability and waste reduction to support sustainable practices within the humanitarian sector. They should conduct continuous training and educational campaigns to raise awareness about safe medical waste disposal among communities. They should collaborate with private entities to align emergency waste management practices with national regulations and provide technical support for bio-based solutions. And lastly, for the humanitarian actor, they should partner with research institutions to promote environmentally friendly waste management practices and support policy creation through research and knowledge sharing. For the waste management service providers, they should partner with healthcare facilities to create customized waste management plans, ensure that processes for waste segregation from the point of collection to the final efficient and comply with national regulation. They should invest in modern, environmentally friendly waste treatment technologies such as autoclaves, microwaves, and advanced incinerators that suit local contexts and reduce environmental impact. They should extend service provision to remote and underserved areas by establishing decentralized waste collection and treatment hubs. They should initiate programs to raise awareness about waste management among healthcare workers, waste handlers, and the general public to foster better practices and understanding. They should collaborate with international partners and humanitarian organizations to leverage expertise and resources, improving waste management practices and efficiency. For the government, they should invest in building and upgrading waste management infrastructure, set aside a dedicated budget for waste management, including resources and personal protective equipment. They should invest and promote the use of non-burn technologies for medical waste treatment, such as microwaves, autoclaves, and chemical disinfection to reduce environmental impact. They should promote strategies for waste reduction and encourage the shift away from single-use items to more sustainable alternatives. They should recognize waste handlers as essential service providers, develop and implement comprehensive training programs for both healthcare workers and waste handlers to improve their skills and knowledge. It should introduce a digital waste tracking system to monitor waste from the point of generation to the final disposal. This system will enhance accountability and provide valuable data on waste generation rates. They should investigate opportunities to repurpose non-infectious medical waste, explore bioconversion of solid waste into bio-based products, and adopt the decarbonization and strategies to minimize final disposal. And lastly, the government should strengthen legislative policies on waste management, revise existing frameworks to incorporate bio-based solutions, and support improved medical waste management practices. This is the end of my presentation. Thank you for listening. Over to you, Dr. Pong.
Thank you, Helen, for that presentation. I think one of the key things that we can identify from this presentation is the contrast or the difference between what's happening in public health systems and the private health systems. We can see how way medical waste is managed within the public system. And this was quite a concern to us as well. And this is the reason why we opted to try and look at what's actually happening in other private entities, what's happening with research institutions, and even other humanitarian organizations. You could see clearly the difference in the systems that are in place. And one of the reasons why we also highlighted Cambridge is because of the institutionalized system of managing waste, where a different category goes through different stages until incineration, and even making use of the liquid waste that has been treated. We were also informed that even the water that finally ends up in irrigation systems is quite safe and is often sampled for even test to ensure that it's actually safe for that particular use. I must also say that we were also very impressed with some of the processes that other humanitarian organizations are using. And this is part of the reasons why we also highlighted MSF in this particular presentation, because it also came out as an organization with quite a strong system in waste management, and that was quite key for us to use as an example in which we can do a benchmark or support other public organizations to witness what's actually happening with other organizations. I want to also mention that out of all this research that we did, the 5 key gaps that we identified, and this cuts across nearly all the organizations that that we visited and those we talked to, is that there is obvious need of a well-functional waste management system. This is something that we identified as still quite weak. The organization already have one, but there is a room for strengthening waste management systems that organizations put in place. Most of the time, we also identified the use of incinerators or burning chambers, which is still a harmful disinfection method. So this is quite a gap. A lot of facilities still use this. And in the event of emergency cases, there are temporary incinerators that are installed, which is still not the best environmental practice. But most importantly, we also noted the training deficiency and inadequate capacity development among waste handlers themselves. One of the key things we noted is that most facilities hire waste handlers on casual basis and with no formal training on how to handle waste. Sometimes they go ahead and actually train them, but because this is a contracted service, sometimes the service provider changes or bring in a new batch of waste handlers, so they go through trainings again. Sometimes they don't get the opportunity to. And the other element that came out very clearly was the lack of PPEs, which was quite at hazard to even the waste handlers themselves. So issues of occupational safety of the waste handlers came out quite clear, and particularly because of the lack of proper PPEs that would protect them from the dangers of handling medical waste. And so what we noticed is that because of the lack of adequate budgets, the facilities do not often allocate budget lines for this for treating or for handling medical waste. And this is one reason that has been cited over and over. When we attempted to ask more questions around this, some of the concerning responses that we were getting was that uh, if you would push for a budget line for medical waste, and then you would be asked that what is it that you need more? Do you need us to get you more drugs, or do you need us to get you bin liners? So it puts the process at a crossroads, because then you ask yourself which one is a lesser evil that you want to address. So these are some of the key issues that we were able to identify, and then we thought, let's go through them as partners, as stakeholders, providing medical aid, emergency medical assistance, and even the governments that makes policy around this area, so that we can identify what actually needs to be done. So part of the process that we went through last week in our face-to-face validation was this. And upon presentation, we were also able to get more insights from the participants. So I want to open this to the floor so that we could get some reactions from you, and also some additional comments that we can also use to keep strengthening this report in terms of what you guys thought about the key gaps, what you guys thought about some of the recommendations that we were able to highlight for healthcare facilities, for humanitarian actors who are here as well, for even waste management companies who are also represented here, as well as the government themselves. So I want to open the floor for this particular discussion, comments, or some additional inputs that we can get. So please just feel free to raise your hand and then unmute yourself to contribute. Yes, so we'll start with Oyaro Stanilas. You're on mute. If you're speaking, just unmute yourself, then you can speak. I'm not sure if I'm the only person who can't hear Oyaro. Can anyone else hear him? Because I think he's on mute. Okay, so I think we'll proceed to someone else. The audio from Oyaro is not quite clear. Yes, yes, okay, just unmute yourself.
Thank you. Mine is just to appreciate the work done by Helen, yourself, Dr. Shadrach, and your team. It was a good thing to do the research, because actually some of these challenges we also get the challenges as the service providers. My name is Hawkins, as you can see, General Manager for Boredo Supplies Limited. We own an incinerator. So we have an incineration site where we do incinerate the hazardous waste or the biomedical waste. So the challenges that I can see, some of them has been raised. If you could really find solution to bridge those gaps, this would be awesome. But once again, thank you for the good job.
Thank you very much, Hawkins, and we do appreciate what your company is doing towards this, and we are looking forward to keep partnering to address this issue around medical waste management. Can we get any other reaction from the rest of the team? Just feel free to unmute. You can raise your hand or unmute and contribute. Yes, Nicholas.
Thank you very much, Professor Pon, and thank you the Pamela Steel team for the initiative and the good work done. Unfortunately, I happen to be on the road, so I may not make very clear contributions, but I've gotten the discussion. I'll be able to pen down a few things, then I'll be able to share with the Secretariat. But just 2 points for you to take home. Number one, management of medical waste processes and other hazardous waste is a very capital-intensive process. So we may try to look at what is the input and what should be the cost, and is there any room that it could probably be a business venture or is totally a capital expenditure. Then number two, we shall talk about the cost of statutory requirements and the compliance, licensing, audits, air quality, among others. How much do they contribute in, and how is it possible any firm that is interested to get to this business can be able to meet that, or is it totally an impossible business? I'll be able to share a few notes with the team for consideration. Thank you.
Thank you very much, Nicholas. We do appreciate your contribution. Priyanka, did you say something? I think you popped up on the screen. Please go ahead.
Sure. I wrote it out on the chat, but basically, I think it's a very well thoroughly done research. I think the entire considerations you have captured from the different interviews of the different surveys and stakeholders, but also the communities is definitely very clear, I would say, and very to the point. But what is interesting is how you've also noted, both positive and negative feedbacks. I'm particularly interested to see how towards the end, the recommendations and some of the next steps that you talked of, how they will actually be adopted by the different partners or the different owners of those recommendations. And I think the most crucial part is that ownership or sort of like next steps from the private sector and the manufacturer industry, because I think that's also where this conversation is very centered to some extent. So yeah, I think it's overall, it's, good job, guys. It's really good.
Thank you very much, Priyanka. I know we had this conversation when we were doing the research ourselves, so we do appreciate your contribution and commending the job that has been done. I think we must also mention that the second phase of this work is to do now local campaigns on the best practices and basically communicate these recommendations and find out a way of having them, when possible, institutionalized so that we can have better waste management practices across board. So yes, Cornelius, if you can hear me, just unmute yourself and contribute. Over.
Okay, good evening. Mine I just wish to make a contribution on this waste handlers, that they should be put more emphasis also on vaccination, because at times these vaccination like hepatitis A and B are very necessary, and influenza also. So thank you.
Thank you very much, Cornelius. And this came out clearly even around issues to do with the occupational safety. We do appreciate that contribution, Cornelius. These are some of the key issues that we also identify that needs addressing. Maite, do you have any comment? I thought I saw you type something in. I couldn't see it come out.
Sorry, yeah, no. In fact, it's because I need to jump to another meeting, and I was just going to say that yes, thank you for the research. I support what the other colleagues were saying, and especially this part of operationalizing the recommendation given, that will be very useful. That part, so yeah, that only contribute.
Thank you. Thank you, Maite. We do appreciate your contribution. I know we have also had quite a conversation multiple times around this work, so we do appreciate also your time to join in between other meetings. Yes, Rufus, I see your hands up. You could unmute.
Okay, thank you so much for the presentation. It was quite informative and also quite detailed in terms of the findings and also the recommendations and conclusions. I think there was the previous speaker who talked about the capital intensiveness of the medical waste management. But I think what we need also to look into, yes, we like also in the presentation there was this consideration that we in terms of priorities, we can say, can we prioritize waste management rather than medical or drugs or something like that? But I think also we need to look at it from a infectious point of view, and also like where we are heading to in terms of this climate changes, climate smart approaches, and this going green approaches. Because in as much as it is a capital intensive, but also the proper waste management also reduces, even in the medical facilities, it reduces these nosocomial infections. So I think also in as much as we need to reduce the cost, but also let's consider waste management could also be a way of reducing some infections, and also for public health itself, it's a very good move that we can do. So we cannot start big, but let's start slowly. And the first thing, let's try to work. I don't know how we can advocate or lobby for a proper waste management policy for the maybe count, then we move to the national level and the like, so that at least this will become functional. We may usually have these national policies, but they are always in on the shelves and not functional. So we need to have a drive to make the waste management policies functional and also be updated with the current trends that we are having. This is my feeling after having seen all these differences that we have with the public health facilities, private facilities, and humanitarian organizations and the like. So at least we need to have a national policy that is followed, that is adhered to. Like when we're doing some assessments for the waste management companies or service providers like Boredo, we could see the NEMA requires us to have like a transportation license, incineration, disposal, and the like. But you could see not all the companies even who are into that service have all those licenses, but some are operating and doing quite big job. So I think like it has to be also enforced. First to have the policies, then enforcement of the policies. Then we can also consider this investment for sure, looking at the health side of it. Thank you.
Thank you very much, Rufus. Very informative. We do agree. And I must also say that in our physical validation workshop that we had last week, we had NEMA representatives, and they were quite vocal about issues around compliance and licensing. And we also managed to get some of the recommendations even for them during that particular workshop. And as I mentioned earlier, we will be sharing some of these inputs that we got on how we can basically work around waste management together, from compliance, regulatory, to government, health facilities, and all stakeholders that are involved. Thank you very much. Thanks, Maite, for letting us know. Please feel free to jump off to the other meeting. So team, do I have any further comments from anyone else? Please feel free to unmute so that you could share some thoughts with us. Okay, I hope I'm not cutting someone else out of the conversations. Do I see a hand? No. Okay, team. I think if you do not have any further comments, I want to once again thank all of us for participating. I know that this is an ongoing process, and we will keep engaging all of you separately as we keep getting more information on how best now we can have some of the solutions that we are coming up with adopted, and how we can keep talking about the recommendations to the owners and come up with solutions that would help address issues around medical waste management. So thank you once again for getting time to attend this. This was quite important process for us, and we do appreciate your time. I want to invite my colleague Helen to come in and say a word or two to close this for us now. Over, Helen.
Thank you, Dr. Pon. So to everyone, thank you, all of you, for your active participation and your valuable contribution today in this workshop. I believe that through the collaboration, we can be able to enhance our medical waste management practices and be able to make a significant impact. As my colleague had mentioned, once our report is done, we'll be able to share with each and every one of you so that you can be able to have a look at it. And moving forward, we look forward to the continued collaboration with all of you in this initiative. Thank you so much, and enjoy the rest of your evening.